My name is Nik Sabharwal, and I have been a consultant cardiologist within Oxfordshire since 2009 and have a particular interest in cardiovascular imaging. For the investigation of chest pain and diagnosis of coronary artery disease, I usually request a cardiac CT scan. For the past few months, I have been offering my patients the CaRi-Heart analysis that applies artificial intelligence to routine cardiac CT scans. This demonstrates how inflamed their coronary arteries are. It gives me a personalised assessment of their cardiovascular risk and helps me make a better informed treatment decision. I have been following a patient for the past 10 years. He has a family history of coronary artery disease and had a cardiac CT 10 years ago that revealed mild coronary plaque. I felt it was severe enough for me to prescribe 40 mg of atorvastatin once daily, which was increased to 80 mg by his GP due to subsequent raised lipid levels. He complained of side effects from taking statins, but continued taking his treatment and his cholesterol remained reasonably well controlled. He does yoga, exercises regularly, doesn't smoke, and has a relatively healthy diet, except for an alcohol consumption that I found to be excessive. He came back recently with atypical chest pain and had an updated cardiac CT scan that revealed more calcified plaque without any flow limitation. The increased calcification was expected as a result of the statin therapy. To have a better idea of the current situation, I suggested the patient have a CaRi-Heart analysis, which revealed extremely inflamed coronary arteries despite his statin therapy and apparently healthy lifestyle. Compared with people of the same age and gender, he was above the 95th centile, indicating a very high risk of a future fatal cardiac event. The report helped the patient recognise that his lifestyle was not as healthy as he thought, and showed me that I needed to better personalise his treatment. As the patient was well engaged with his medical care, he understood the marginal gain that he would get from all of the individual measures I recommended, and demonstrated willingness to follow this new treatment plan. Number 1. To reduce the side effect of the statins, while keeping his cholesterol levels under control, I halved his statin dose and added ezetimibe. Number 2. I then insisted that he make radical changes to his lifestyle. Firstly, to drastically reduce his alcohol consumption, and secondly, to improve the quality of his exercise by using a personal trainer. Thirdly, although his blood pressure was reasonable, I decided to initiate ramipril, given the beneficial effects of this drug shown in the HOPE trial. We will also consider introducing low-dose rivaroxaban to reduce the risk of atherothrombotic events. I will closely monitor how these initial measures work for him and have already anticipated possible amendments to this plan, such as adding in low-dose colchicine. The information provided by the CaRi-Heart analysis provided important additional information above and beyond standard cardiac CT reporting, giving me for the first time information on coronary inflammation and its associated risk that allowed me to personalise both risk assessment and treatment decisions for my patient.